test. You scoot over here like this. Anterior drawer tests for the integrity of the anterior talofibular ligament, which sits right here. The individual is in this position so we can stabilize proximally on the distal part of the leg. I'm going to grasp the calcaneus, distract, and then I'm going to provide an anterior displacement like this. The foot needs to be in some element of plantar flexion so that it's more unpacked, open-packed. Okay? A positive sign is more than 5 millimeters of displacement and or pain that's localized right here. That's the anterior drawer test. Let's see, Taylor tilt test. Let's do Taylor tilt. Taylor tilt test tests for the integrity of ATF, CF, PTF, depending on what amount of dorsiflexion or plantar flexion that we put you in. When we do this test, you can be straight like this, you can be down like this, that really doesn't matter, you can be lying on your side, however it's easiest for you to apply force. You proximal stabilize, you grasp the calcaneus and distract slightly. If you're in full plantar flexion with a tilt, which brings you into an inversion, that will stress the ATF. Pain will be localized here. If I put you into a neutral dorsiflexion plantar flexion and invert, that will stress the CF, localized pain just inferior to the malleolus. If I dorsiflex you and invert, I stress the posterior tibiofibular ligament or talofibular ligament. Okay? So I get posterior, CF, anterior, as long as I apply this tilt force into an inversion. Kliger's test, also known as an ER test depending on where you put your hand. The Kliger's test will test for two things. If the individual is in plantar flexion and I stabilize proximally and grasp the distal part of the foot, everting him with plantar flexion, I stress the deltoid ligament. Localized pain right here. If I dorsiflex and evert, I'll put stress between the tibia and the fibula, and I will get a positive sign of pain up here for a syndesmotic sprain or a high ankle sprain, the interosseous membrane between tibia and fibula. So that's the Kliger, or the ER test is just putting my forces here or here instead of across the foot. Squeeze test. Squeeze test, the individual can be like this, they can be supine, 90-90, it doesn't matter. Point is that I have to grasp the bones, fibular head with this hand, medial portion of the tibia with this one, and I squeeze. I work my way down the leg like this until I reach the malleoli. The higher I feel pain as I do this, the more severe the injury. Okay? Nothing, 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 nothing. Pain is a low injury. Pain, 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 pain is a really high injury. That's a positive sign, is pain when squeezing. Thompson's test. Let's have you turn over onto your stomach. Individual bends their knee to 90 degrees. You grasp and stabilize distally. You grasp the calf and squeeze. This is a negative sign that's being shown right now. A positive sign is no movement of the foot when I squeeze, because this tests for a complete rupture of the Achilles tendon. Positive sign, I squeeze, nothing happens.
Hi, good day to you, Dr. Liza. So today our group, which is Ilya and myself, will be presenting to you the anterior tibiofibular ligament injury. So we'll be presenting on 4 different types of treatment which targets on the range of motion. 1, 2 will be on the strength training for the ankle, 3 for the proprioception, and lastly, which is the application of taping to the injury to help it to recover so that a person can actually return to sport on time, as well as to rehab without any more recurrence, avoiding recurrence. So sit back and enjoy. Okay, so Ilya will be presenting how do we do range of motion for active plantar flexion and dorsiplantar flexion. So the first part, she will be doing the active plantar flexion. So that is active plantar flexion, and then dorsiflexion. Dorsiflexion. And this will do for 20 to 30 seconds for each movement. To stay there, and after 30 seconds, change to dorsiflexion. Alright, change to dorsiflexion. And the next part for range of motion is the active inversion and the eversion. So first we'll be doing the inversion. Alright, so that will stay for 20 to 30 seconds also, and then change to eversion. Alright, so this second part of range of motion must be noted that the person or the patient shall not do it when they had the injury for the first and second week.
I'm back.
As for the strength training, the passive dorsiplantar flexion is also recommended to be done using the resistant band for a frequency of 8 to 12 times in 3 sets, with every set an interval rest of 10 to 15 seconds before changing to the other position. Meanwhile, after the passive dorsiplantar flexion exercise, patient may also do the passive inversion exercise using the resistant band with repetition of 8 to 12 times for 3 sets and 10 to 15 seconds of rest during the interval change to strengthen patient's PTFL. Then, patient may also change to the passive eversion exercise with the same reps and sets to strengthen their ATFL. For the balancing exercise, patient will start with a lower intensity using the roller board. First, patient will start with both legs standing on the roller board and arms wide open for 30 seconds. Then, do another 30 seconds with her eyes closed and try to balance. Secondly, patient can do the exercise with a hugging posture for 30 seconds and another 30 seconds with her eyes closed to challenge her proprioception and her balancing. Now next, the patient will attempt to balance on one leg with her arms wide open. Then, attempting this posture again with her eyes closed. Both will be done for 30 seconds. And last but not least, patient will repeat this single leg balance exercise in the sequence like previous with a hugging posture for both 30 seconds with the eyes open and with the eye closed. Now, make sure that patient steps on the middle of the board to in case any injury or falling will happen. Taping can also be a rehabilitative method to help in recovering the injury of ATFL. Firstly, measure the area and cut the strips roundly at the edge needed to make sure that it does not get caught on the shirt and peel off as soon as it is being stitched. Then, preload the ankle with some intensity, about 30 to 40% of stretch from a little bit higher of the malleolus and then go around and connect to the other side of the malleolus with a little stretch. Then remember, after sticking, you're required to take the tape paper to actually cause a little bit friction on the tape by rubbing it. Next, use a smaller strip to perform a decompression with about 70 to 80% of stretch in the middle of the strip on the ATFL position. Now make sure the ends of the strip are not stretched. Lastly, stabilize the ankle with the last strip that we have cut earlier on the Achilles area. Make sure that you use the paper that is with the tape to create the friction so that the tape will stick on properly. Then we are done.